for kind invitation. And my topic today is advanced bone grafting. What are the basics and where are the limits? And we have only 40 minutes, so I chose the, let's say, most advanced cases. We are going into vertical, so stay tuned and you can really be excited. Good. In my clinic, I'm working 100% with pure autogenous bone. There is only one exception when it comes to sinus, where we are working with the bone substitutes, but in all other cases, since more than 11 years now, I'm working with purely autogenous bone, and this is possible. And meanwhile, many more colleagues all over the world are following this. Fail. What do I mean with that? So I think we all failed in the past, and this is also a chance to grow, to go to the next level, to get up again. And also the AAOS summit and also the American Academy for Oral Surgery is actually a good chance to grow in these things. My father, he was also a dentist, so he placed implants 45 years ago, so you could call him one of the pioneers in implantology. Like all colleagues those times were pioneers, and I think it was very brave to do implants actually, though you didn't know if it works, what will be the long-term result. So I'm asking you now, do you think nowadays it's much more easy? Do you know, we know exactly now 45 years later that we know exactly what to do to come to a perfect result, especially in compromised cases? I think it's still challenging. And my answer to this is because we have a surplus on information. So we have Google, we have the World Wide Web. Nobody of you, including me, has the time to go through all this information, through all these studies. So actually at the end, you're confused because every week you get new information, new materials, new techniques come on the market. And I think it's not a secret to understand that behind all these materials and techniques, there are also interests, at least behind most. And so when you're doing studies, for example, the first question, for example, when I would go to university clinic, will be the question, who is going to pay for it? Who will sponsor it? Who gives maybe a few €100,000? And usually these are companies. And what results do they want to have? Of course, good results to sell their products, which is okay. I think that's how the world goes. But you have just to understand this, that you know when you're looking at the study, how this is done. And the more I feel actually happy and glad today to talk about a topic which has no sponsor, which is autogenous bone, the patient's own bone, which will still state as the gold standard. So I don't want to bore you with my CV. Also, Keanu Shah told already about this, but I'm coming here from Heidelberg. And the time which influenced me most was time at my former Professor Curie, where I was also senior physician. Since 2012, I have my own clinic close to Heidelberg. And we are also giving lectures now and courses, of course, during much offline courses, but more we are doing much more online now. But if you're interested, check .com. And usually I'm all over the world every week, giving lectures about working with real bone. But nowadays more online. And Keanu Shah said already, this is the which started everything, the Real Bone Builders Facebook group, which is not even 10,000 anymore. We hit the 15,000. You see here also, please follow me on Instagram if you have, because it's very exciting. Most of the cases I'm sharing there are not my cases anymore, but cases from all over the world, from colleagues, from former students, and I'm so proud. And also have a look on these wonderful results. And this was one of the last congress I've been. This was in China, end of the last year, in close to Shanghai, with 1,000 colleagues, and it's actually quite new there to talk about autogenous bone. So it's not so common, but I'm working that we can change that. So this is my clinic, my team. I'm very proud to have them in my behind me, and they support me. And we do also general dentistry, functional disorders, endodontics. Me, myself, together with a maxillofacial surgeon, we are doing only the surgical part. And also here you see in the lower left corner, we are giving usually then live courses with live operation. Meanwhile, we are doing this live operation also online. So if you're interested, just let me know, just get in contact with me in Instagram and I will let you know what we offer now. And for those of you who haven't been in my home city, Heidelberg, when I look out now of my window, I see exactly what you're seeing now. This is actually, it's a small village. This is the River Neckar and the old bridge from the 13th century. And usually also when we are having group here, we do also a city tour. This is the old castle from the 17th century. And yeah, finally the old town with the longest pedestrian zone in Europe. So yeah, to summarize, old bridge, old castle, old town, everything old. Let me ask you one thing, is old good or is old bad? Strange question maybe. At least when you're looking into the program of a congress, you read only new, innovative, but never old. But I think old is much more powerful because the techniques I will show you now are 20, 30 years old and the material even older. We are talking about millions because it's the real bone, the real miracle of nature. And I think this is much more powerful than all the materials which are coming on the market every week. So, but I was not always doing biological bone augmentation, working with autogenous bone. I was also trained in GBR first. And when I looked at the case like this, let me ask you, how would you plan this case? I was trained, okay, if there is you remove a tooth, you have a hole, you have to put some substitutes inside for a better healing. Do you agree? We come to the answer later. And okay, in some areas you can place implants right away. But in some areas, not. And those areas are actually the most challenging. And when you're an expert or you want to become an expert, you have to get along also with those areas where you have thin grafts or even vertical situations, vertical deficiencies. So also in these cases, I used a lot of bone substitute just covered with membranes. And you know, when you're starting out, you're very brave, you believe what the companies are telling you, but when I had my first failures, I felt not so fine anymore. And I think you also have this feeling when you have a failure, it's not just a case which is failed or just an implant. No, it's a human being behind, it's a person. It could be your friend, your family member, or whoever. So actually, this is not what you want to have. And definitely in my hands, GBR didn't show these, especially in compromised cases, predictable results that were promised to me. So the first failures occurred. I didn't do statistics those times, but I would say maybe 30% of failures in this difficult. On the other side, 70% success. So is it good now? Is it bad? So at least when you have your own clinic or your own practice, you know that this is actually a disaster to do every third case, especially when you referred cases. If you get referred cases, usually which cases you get referred, not the easy ones. So even the general dentists, they're doing the easy implants themselves. So you have to be prepared for the difficult cases and to get here almost 100% predictable results. So focus on failure and say, or on success. And I think only if you focus on failure, so you can really grow. And then I was actually a little bit scared. And I changed my protocol because I didn't want to have these failures anymore. And instead, I avoided overall to do these augmentative, heavily augmentative procedures. I became more minimal invasive and I used smaller and thinner diameter implants, which also lead to some problems. And yeah, what did I do to these areas? Actually, I tried to plan around the difficult areas. And what else can you do when you're not able to place implants in the molar area because you have to augment the bone there? Just remove the teeth and place there your implants. Maybe you're all on 4. Easy, right? But would you do this also to maybe to your daughter or to your mother? I guess not. Don't get me wrong. I think all-on-4 is a wonderful concept, but many times I see wrong indications. So teeth get removed, which are still okay, or just have maybe a little bit periodontal disease and some little bone loss, but actually you could keep them, but you just have to focus then on the bone augmentation of the posterior area. Then it was first time that I heard about augmentative procedures with the autogenous bone. And I was asking my colleagues, what do you think about working with real bone? And they said, oh, I think that's very dangerous because there's the nerve. And yeah, it's also very painful for the patient if you're taking a block. And overall, after these situations or explanations, and they also said, patients, they don't want that you're taking blocks from them. I felt stuck. Obviously, that was not the right way to go. And maybe some of you also feel same now. And but then I had two situations which made me think again. And one was a good friend of family, like I said before. And my father, who was also a dentist, was placing the implants here 30, 35 years ago. Old IMZ implants, you might still know that, or the older colleagues from you. And we had here some perimplantitis, and he told to our good friend, no problem, my son, he is oral surgeon, he can fix that easily. But those times I was only trained in GBR, I didn't have these results how I wanted to have. And we have a vertical defect in the posterior mandible, very high muscle activity, so very difficult. So, and a success rate with 60 or 70% was not enough to me. And actually, this is more like I felt. I was scared. And what did I tell her? I told her, so we have to do prophylaxis, we have to stabilize the situation. And yeah, but overall, what was the actual reason behind? I was just too scared. I was anxious for going for the explantation, going for the vertical augmentation. And then I had also another situation. It was a young woman. I was there in another private clinic. It was like a implant factory. We placed more than 100 implants per month. And so my former boss, he was doing the main part of the implants. I was assisting him. So it was this young woman. It's not her, this from stock photo now, but she looked very similar. And he always did the same, let's say, principle. He tried to get primary stability with the implant. So he always did implant placement and bone augmentation together. So the exposed threads, he just covered with bone substitutes, placed the membrane over it. And sometimes it worked, sometimes not, but really nobody really cared about the patients there. It was like a lot of money. And so the human being or the personal individual was actually not in the center. And also in this case, it felt very horrible. She had the missing anterior incisor in the mandible, very sharp crest, and he did this GBR. He placed the implant, covered the threads with the screws, and it's exposed. She lost all the bone substitutes, had a big recession. Still, it was integrated in the lower part, but really bad result, and I felt very sorry for her. And I even blamed my former boss for doing this to this poor young woman. And I didn't say it, but I felt like. But I'm asking you now, is this fair to blame somebody if you don't have a better concept? Because I didn't know how to do it better. Maybe I would have done it in two steps, like first building some bone substitutes and then placing the implants, but this was not the real concept. So I would have failed probably for sure too. And yeah, so I really had this need now for a strong concept. And then it was really by coincidence that I was in the biggest congress in Germany for oral surgeons and maxillofacial surgeons, where I was also, I felt very honored that I was also on this stage last year, speaker. And yeah, it was first time that I saw my former mentor, Professor Curry, talking about biological bone augmentation, about real bone. And it was just fascinating. And I asked him to send him my documents to get a place in his clinic. And I was lucky, I got a place in his clinic. I stayed almost 4 years in his clinic. And we got more than 80% of our cases were complication cases, pre-operated, very difficult cases, mainly with bone substitutes in advance. And we were still able to handle this situation in almost 100% of the case. You see on the left side, Professor Curry, on the right side, Dr. Schmidt. I'm very grateful to both of them that I learned from them. And this was me. Maybe you recognize me still with hairs those times. And yeah, I also became senior physician. And from that moment on, I really felt that I have to bring these methods into the world. And I used first time, because Professor Curry is not on Instagram or Facebook, I built the Facebook Real Bone Builders group with more than 15,000 colleagues now. I built Instagram, more than almost 22,000 colleagues from all over the world. So please join us there, and yeah, also share your cases when you're working with autogenous bone, real bone, because this is definitely the future, even if it has no sponsor behind. And before we are coming to the case I chose, because time is limited today, because there are fantastic other speakers coming afterwards me, I want to show you the CCRD classification, which is a consensus paper, which is actually showing some guidelines how to handle this situation. It was made from the Federal Association of Implantologic Active Dentists in Europe, and it was made from key opinion leaders from many countries in Europe. And the goal was to give a classification of defects for regular cases with bone augmentation. And you might know already former classifications like from Cabot and Howell, 1988, or even more famous from Seibert, 1983. And here it was very interesting when you look more carefully that we have, when we are looking at the resorption patterns, in more than 50% of the cases, we have actually mixed forms. That means we have not only horizontal component, we also have a vertical component. That's very interesting to understand, because these cases, actually, we have to regenerate them. And before I show you the table, you see here how is the differentiation. We differ between the kind of defect, which is horizontal or vertical or combined defect, like I said before, or as a special form of the sinus. We have the size of reconstruction needed. So we differ between small, medium, and large defects. And finally, and this makes this guidelines or this consensus paper outstanding, we differ between, first time, between inside and outside the contour defects. What do I mean? So I brought an example with me. So you see here in the upper picture, a typical inside the contour defect. That means you have a lot of bone walls, which makes the regeneration in these areas much easier in comparison to the lower picture, where you see just a thin crest. That means you have a one wall defect. Here, of course, you have to build the new bone first, the foundation, before you can place the implants. And this also already answers the question, when can we do the bone augmentation same time with the implant placement same time with the bone augmentation? And the answer is, so whenever your implant threads are exposed outside the contour, you should do it in a two-step procedure. First, build the foundation, the bone, and then you can place the implants into it. And when you see first this table, first time, it might be a little bit confusing, but we will go over it and then it will be very clear to you. On the left side, you see the different procedures. So we differ between bone split, intra-collected bone chips, bone block, and also the hip bone. Below that, you see now GBR methods, first pure, and then together with osteoinductive bone chips, and finally distraction technique and sandwich osteotomy, which will not be the topic of this lecture. And then you see the different defects. You see here horizontal, vertical, and combined and a special form of the sinus. And below that, you see less than 4, 48, and more than 4, which means the size of the defect. And overall, on the left side, I put a circle around. You see here the inside the contour defect, while you see on the right side the outside the contour defect. So the inside the contour defect are actually for beginners or for intermediate level surgeons, but especially these difficult cases with outside the contours on the right side, this is really for experts and for those of you who want to become expert. And this is only possible to do this with the gold standard, which is autogenous bone. And I know you have seen these mechanisms already 1,000 times. Sorry for that. Now you're seeing it 1,001 times. Only autogenous bone is able to give osteoinduction. That means initiation of bone regeneration. It's also osteogenetic. That means it has the ability for angiogenesis, building new vessels. And of course, autogenous bone also works as osteoconduction or as a framework or a scaffold and brings this effect of osteoconduction with it. And this was a case a couple of years ago in my clinic where, this patient, he had a bicycle accident. He also got a trauma or a fracture of the mandible, got treated in another clinic. They also did the reconstruction, the frontal area, because he had lost his teeth, and they did it with a full cortical block. And then the patient became patient in our clinic and asked me to place the implants, but I told him, I don't know what we will find. I knew that in this other clinic, they are working with full cortical blocks, but this is, in my humble opinion, the past. And so I told him it might be that we have to do the bone augmentation again. So I opened them up, and what I saw was here on the right side, white bone. So it was integrated, you see, in the apical area, but it was white bone, and this is of course not what we want to get. And I still did not tear it apart. I left it, I placed the implant slightly deeper, and it still looks stable, but you never know when the resorption will come. So because you know this expression, some people say, yeah, autogenous bone, this is like snow in the sun, it's melting away. And but this comes from these former cases like you see here, full cortical blocks, because the bone regeneration or the revascularization takes too long time. That means part of this block dies, and this gets resolved over time from osteoclasts and macrophages. And this is not what we want to have. We do not want to have white bone. This is the past. And nowadays we have the new concept invented from Professor Curry, my former mentor, biological bone augmentation with a split bone technique. That means we are separating the block into thin bone plates, then we are crushing it into small particles, and overall at the end we have an enlarged surface by using these particles. That means we have a faster access from the blood vessels. That means faster revascularization, faster nutrition. That means we have vital bone at the end. And this is maybe the most important message from this presentation. So you see, we are placing these plates then on distance. We are creating actually a space. This container is filled in with the chips, and at the end what you see now is red bone. And if you took a biopsy here, what would you find? Real vital bone. There is no difference to how the bone was before. So, and I really can tell you that this is real bone. So my brother, for example, he's also orthopedics and emergency doctor. You know, we are here in Germany. We have a Autobahn, unlimited speed highway, and those guys who are not dying and have an accident, maybe 30 of them, 30, maybe some of them have 30 fractures. They are coming in the clinic where my brother is actually treating them. And those who are surviving, after half a year, it's all healed, 100% healed. So it's not like we know from soft tissue where we have scar tissue afterwards, where we have compromised. No, this is the same bone like we had before. And of course, we have to give function loading. We have to place implants. If not, we have resorption. But afterwards, it will be 100% stable. Okay, this is the most important message. Also, if companies are telling you, no, you have to use whatever stones and bone substitutes that it stays stable. No, this is just imagine. This is marketing, and they want to sell, of course, their bone substitutes, but autogenous bone stays vital and stays there. And we are coming now to the case. It's a vertical case. And of course, we are here now. This is the domain of pure autogenous bone. Look here to below that. You see on the left side, GBR. GBR is absolutely no indication. Also, when you put maybe an allogenic block or a ring or whatever on the crest, this is not working. It cannot work, maybe in a few cases. But there is no signal, no impulse that says to the bone, grow out of your envelope into this osteoconductive materials if there is a one wall defect. It makes no sense. So this is the reason why it's not predictable at all, because it's not osteoinductive and also not osteogenetic. This is the reason you have to work with more powerful materials and techniques. And this was a case you see here in the right upper maxilla. So we had to remove because we had here some bone loss. We have now a big vertical defect. And I want to show you here, that's also why I chose just one case step by step how to treat this case. And yeah, it was also treated before. Try to do this periimplantitis somewhere else, but yeah, it did not work. You cannot build bone around the periimplantitis implant. And you see here the situation, you see the vertical defect. And yeah, we chose now an approach. It's called the semi-lunar tunnel approach. It's like a half moon or C-shape approach. So we don't do crestal incision here. So for those of you who are interested also so we just created a masterclass with more than 35 hours of video content, weekly live course. You can discuss with me your upcoming cases. I give you personal mentorship. And when you're interested, just get in contact with me via Facebook or even better via Instagram, and I can give you more information. So it's a very exclusive small group, but those are doing really big steps ahead to become very good in these techniques. And we will also give workshops, online workshops with special equipment. And you see here the semi-lunar tunnel approach. We are starting with a split flap, and then we are going for the bone harvesting part. And here's, I have something for you at the end of this presentation. I have something for you, a little present, because it's for free. It's my book. The online version is for free. Biological bone augmentation, safe bone harvesting protocol from the external oblique line. All step-by-step protocols, all tips and tricks how to collect the bone from that area, because I figured out over the years that this is the most crucial point. People are a little bit scared of taking the block, and I will show you step by step how to do this in a very simple and very fast way. And because then you have the gold standard, so you are also saving so much money. Imagine you are working with only the pure autogenous bone, not that you don't have to do operation twice. You're also saving money for the bone substitutes, money for the membranes, and yeah, actually it's a lot of money you're saving over the month and over the years, even $100,000s of dollars over the years. So, and especially those of you who want to become expert, maybe younger colleagues, there is no way around. Let me tell you, there's no way around of learning these techniques. And you know, also many other colleagues like Maurice Alama, like Howie Gluckman. So they are all doing these techniques, and they are absolutely 100% standing behind these techniques. And the first incision, actually, you're doing in a right angle, to the occlusal plane. Then you're doing a parallel incision to that. You're combining it parallel to the external oblique line, and then you're doing small perforations here in the crestal area. Of course, we cannot go here too much into depth. It's all written in the book, so I will give you the link at the end. And you should not go into the ramus, because here there is the potential risk that that the nerve is on the surface. That means you can come close to the surface, what we want to avoid. That's also why we are differing it into the danger zone, and we should stay away from the danger zone. And again, this is all described step by step, 40 pages in our ebook, free ebook for you. And if you want to get the print version, just €19, you can also get it. So now we are taking a template, and this template is now used to get the right shape of this block. So you see, I put the template now on my block, and I want to give it the right shape. If you cut it, you want to cut it only 90%, and then break the last 10%. You're rounding the sharp edges, very important. Should all be nicely rounded, smooth. The more you can do extraorally, the better it is. Don't manipulate too much on these bone plates. Intraorally, very important. You see, there's a lot of details, and all this described also in the masterclass. For those of you who say at the end of this presentation, that might be interesting for me, and I really want to become an expert in this field. So then you have the chance to become a masterclass students. And so more information, just text me, or also go on Instagram, or on my bio. There is also a link, and you can follow, and you can apply for getting a place in our very exclusive masterclass. So this is the right angle technique. We have two techniques for going into the height. We have the parallel technique and the right angle technique. The right angle technique is shown here. So we are starting with a roof plate. This is fixed then on distance, and this container, actually same like you have seen it before in the lateral, is filled now with bone chips. It's all pure autogenous bone chips. And if you might be curious how we get this huge amount of bone chips, so let me tell you, it's quite easy, because you just use a bone scraper. We also have this bone scraper on our page, so you can also purchase it there. So I give you later the link. It's myimplantbusiness.com. We have also a shop, and also also the education part, both, because it always comes together. You need the right instruments for the right techniques, and for the right techniques you need the right instrument. So it all comes together. And you're filling it, you're condensing it. The more you condense it, the better it is, that you don't have an ingrowth here of fibroblasts. That's what we want to avoid. And we are not using membrane. Some of you might think, oh, at the end of the so I'm putting a membrane over it. There is really no need for it. In contrary, it would even harm the situation, because if you put a membrane over it, what are you doing at the same time? You cut the blood supply. And remember why this method works so much better than when you're working with a full cortical block. It works better because you're crushing it. You have an enlarged surface because you're working with these particles. And if you cut the blood supply, you're losing all these advantages, which we have through the split bone technique and the concept of biological bone augmentation. Okay, BBA concept, how we are also calling it. And then you see, after filling, we put another plate now on the buccal side. Usually on the parallel side, there is no need, because there's also no muscle activity. So no need to put another plate on the parallel side. So this is the semi-lunar tunnel approach. We also do sometimes the tunnel approach, which is also an amazing technique. And so we are fixing it. And you see there is a little gap. So this is now a little bit a detail, because I really want to have it perfect at the end. So I don't look too much to the time. I rather look to a perfect result, because I want to give the patient. I really, this is what I learned from Professor Curry also. He treats every patient like it was really like a good friend or family member. And I think it should also be about ethics and moral those days, not only about money. And we definitely give with these techniques our patients the really best results. And I showed you before, we have to remove all the sharp edges around it, but also this is not enough. Also afterwards, like you will see here now, we have to remove with a round diamond burr. You can do this also the sharp edges once more, because always when you place two plates to each other, it's always creating a sharp edge, and you have to remove this sharp edge to avoid any exposure of this bone. And so we are suturing now, and you see it's actually quite tension-free closure. It's a tension-free closure we're having here now. This is very important to have tension-free closure after the semi-lunar tunnel approach. And this is the situation we are having now after replacing the implants. So after 3 to 4 months only, you're doing the re-entry. You see here nicely regenerated bone. We have a little defect in the mesial area, so we are re-augmenting here the bone. I just use some bone from the tuberosity. And I'm placing this now with another screw. You see here, actually quite easy. So there is no need to go for another block in the mandible array. And this is the situation after. And this is how we start. This is how we are at the end. We do the second stage surgery with the apical reposition flap. So I started 3 minutes later, but in 3 minutes I will have finished. So this is the apical reposition flap. You see doing a split flap, and this is the situation after. And I think even if the prosthetic is maybe not the nicest of the world, the patient was very happy, because imagine how he started and how we end. And I want to show you now a study, 10-year follow-up after vertical bone augmentation, and you see less than 1 millimeter resorption after 10 years. Less than 1 millimeter resorption after 10 years. And we are coming to a conclusion. For vertical bone augmentation, we recommend pure autogenous bone. Hard and soft tissue augmentation is always coming or in a symbiosis, and preoperative 3D diagnosis helps, and go not into the ramus. And for those of you who are interested in now and also want to get the free ebook, so go on myimplantbusiness.com, like you see it here, and then go on free media. You will see also a free webinar, and you will see also the free ebook. And for those of you who want to get the print version, please go again on myimplantbusiness.com, go into the shop area, and then go on manual, and you get here this printed version. And also many other colleagues, and you might know the colleagues on the picture, are very happy with this book. And yeah, we are at the end of this presentation. I thank you so much, Fiona Shar, to your prestigious platform, also to American Association of Oral Surgery. I was very glad to be part of it, and I'm looking forward to the next speakers.